Should the elderly be prescribed anabolic steroids?
So there are actually some situations where anabolic steroids have been researched for medical use. This includes severe burns, because burn patients, whole body burns and things like that, is a major like hypercatabolic state. So there's some research in that world. And other syndromes where there is severe muscle and fat wasting, a syndrome called cachexia. So anabolic steroids have also been researched in like HIV, AIDS related cachexia, where these patients are just literally skin and bones, they've wasted away. So this is being looked at. I think part of the reason outside of the obvious like social stigma around this stuff that they're not kind of used more liberally in practice is actually when you look at the available research that we have on this stuff in elderly patients, the outcomes are actually not like mind-blowingly good.
Yes.
And so I think that until such point as that evidence would emerge where we put an elderly individual, presumably sarcopenic individual, not just somebody who's elderly for the sake of it, on anabolics, if we see fantastic results in terms of quality of life or other kind of positive outcome measures, then I wouldn't expect medical societies or organizations to recommend this stuff until we have a solid evidence base to stand on. I think a big part of it is that doesn't actually exist yet, and I'm actually open to the possibility that they may not deliver the benefits that we all assume they would. Rather, I think that we should pull the levers that we know work right now, getting physical activity up and getting the nutritional intake to where it should be. And I definitely think it's reasonable for us to research this stuff. But going back to the root of the question, should the elderly be prescribed anabolic steroids? At this time, no. Wouldn't be my recommendation because we don't have clear evidence of consistent benefit, whereas there is some potential for harm, particularly in elderly who, again, remember the number one cause of death in the US and the world that I talked about on day one yesterday is cardiovascular disease. And there are cardiovascular risks associated with these medications if you were to give them to patients. So we're giving them medications with some known risk from a cardiovascular standpoint and potentially other organ systems that can be involved. There can be side effects on the liver depending on the type of anabolic steroid and the route of administration, as well as on the kidneys and a few other potential side effects and complications for unclear benefit. So we need research to demonstrate clear benefit before we're going to comfortably prescribe it, and that really stands, in my opinion, for any medical intervention that we're going to do. I would prefer to have good evidence of benefit before I do it, and that has been particularly relevant recently with COVID when it comes to deciding how we're going to treat these patients. Yeah, I want good evidence before I decide to give somebody a particular medication that has known risks and unknown benefits.
Yeah, I feel similarly, mainly with respect to the obviously the risk-benefit analysis, but with the existing data on this. If there was robust data showing when you give elderly patients testosterone, they grow huge muscles and their quality of life improves and all this other stuff improves, then I think it would already be widely adopted. Right now you have relatively few amount of studies, particularly looking at muscle wasting and muscle and fat combined wasting diseases. So like Austin said, HIV, burn patients, other diseases that causes cachexia like liver disease, etc. And then a few like fringe papers that like randomly pop up, like using testosterone in women who have chest pain, like angina.
Yeah, I remember that one.
Yeah.
It was weird.
Or now the most recent paper that came out on this is testosterone use in depression. And there's other papers obviously out there on testosterone, but much fewer on other anabolic agents, right? So when people are talking about like oxandrolone or Anavar or decadurabolin or whatever. This is the same case that SARMs, the selective androgen receptor modulators, these are the new drugs that are on the street. Well, they're on the street right now, but they're being researched. These are effectively, they're supposed to be like steroid analogs, like work like steroids, but have none of the side effects because they're selective for the receptors that they actually bind to. But unfortunately, during the phase 2 clinical trials, when they're using them on these older people, they're not getting the benefits that are purported, like bigger muscles, stronger muscles, being able to, be more active or anything like that. And so when you have this data that like overall suggests not a reliable benefit, and then there are known risk factors, it makes sense that the medical community is kind of like, ooh. Even during our boards prep, I remember on like step 1, there was a question about using anabolic steroid, like a patient who was using anabolic steroids, and then like one of the lines was, data at present does not show or shows that anabolic steroids don't provide a performance benefit in sport. Please counsel the patient accordingly. And I was like, oh, Vinny down the street at Gold's might have a different opinion.
Yeah.
So as far as how this works in the future, I think if better data comes out, that'd be useful. In order to get that better data, we need to do more studies. And I think that in general, medicine is fairly liberal leaning. And so as new data emerges, I don't know that any stigma is going to prevent us from adopting the latest practices, provided ample evidence exists.
There was a big series of studies that came out, I think maybe last year or 2 years ago, called the Testosterone Trials. It was a big set of multiple studies on testosterone for various outcomes. So if you're interested in this topic, I'll just look those up and get some results.
Yep.